Our next speaker is going to be Dr. Chris Karras.
Probably like you, I didn't know there would be math at the neurosurgery conference. It's good to have Vic around in the office to help us with our equations, definitely. I'm going to be talking about, well, in the program it says spine oncology, and that sounds very medical, but we have a medical doctor here that will talk to you about that. The title of my talk is Surgical Considerations in Spine Oncology. There are surgical considerations, and many of those surgical considerations overlap with the mechanical considerations that we consider for degenerative spine and for spine trauma. But we do have to know, unfortunately, a little bit of medicine when we're treating spine tumors. We have to approach it differently. And so the goal of this talk is not to talk so much about what sort of instrumentation we would use, how we'll balance the spine, those sorts of surgical techniques. We're going to talk about the algorithms that we use to treat the right patient in the right way, depending on the type of tumor they have. And so you'll see as we go forward, we'll talk about the anatomic considerations and that sort of thing, how the surgery responds to those considerations. But we have to respond surgically by understanding some of the medical features, so we'll talk about those. I'll go quickly through how we categorize spine tumors, some of the spine tumors that are in the spine canal, but I'm going to focus most of my attention on spinal metastasis, which is something that we see most. So generally, from a surgical perspective, spine tumors are categorized anatomically. We have extradural, intradural, extramedullary, intramedullary. And those categorizations are self-explanatory. Most of what we see is extradural, and most of that is metastasis. And that's why I say we'll talk about that mostly. Under the extradural category, there are intraosseous tumors, and it's important to make the distinction between a purely intraosseous extradural tumor and one that has epidural extension. That's an important distinction when we try to treat these surgically. And so this is just a graphic representation and some MRIs that we've had of some of the examples of the categories. And so here we have a purely intramedullary tumor, here extramedullary but still intradural, and then here extradural tumor. So of the intramedullary tumors, astrocytomas and ependymomas, where we are what we see most. There is what's called a myxopapillary subset of ependymoma. That's in Greenberg. It kind of is listed both ways. It can be considered intramedullary, but most often that's extramedullary intradural. And we'll talk about the myxopapillary subset. Astrocytomas, ependymomas, hemangioblastomas. Here, you may see dermoids that form after myelomeningocele closures. These things can all occur. The surgical considerations for intramedullary tumors also are anatomic. If the tumor comes to the surface, you can resect around the tumor. You can do intramedullary tumor dissections. These are possible, obviously. If it comes to the surface, that's the most straightforward. If it has a plane, that's straightforward. There are certain techniques that we use to make a plane. We like to minimize the use of cautery, use hemostatic agents instead. If it's a very infiltrative tumor, biopsy may be ideal rather than trying to do something completely, to try to get a complete excision. There are methods of myelotomy. Midline myelotomy is typical, again, depending on the tumor location. Some of the miscellaneous tumors I've mentioned already. You know, when you're resecting an intramedullary tumor, sometimes it is best to maybe even core it out a little bit, bring the edges in, take it out without expanding the spinal cord as you're operating. For a hemangioblastoma, this is not advised. Hemangioblastoma can bleed considerably, and so again, understanding or having a good differential, a good idea of what type of tumor you're treating will affect how you approach the surgery. And so if you think that maybe a hemangioblastoma, if the patient has a von Hippel-Lindau, it may be a hemangioblastoma. The MRI features are consistent with it. It's best to try to make a plane around these and excise them, and they can be excised completely. Extramedullary intradural tumors, there are some other considerations. These are typically benign tumors, and so if we do get a CAT scan, we'll often see that it's eroding the bone, they're slow growing. But because they have these extensions, because they have these involvement of the bone, sometimes you have to prepare also for a fusion. Intramedullary tumors through a standard laminectomy without facetectomies are very accessible. Accessing the spinal cord, even when it's expanded by a tumor, can be done through a laminectomy in most cases, unless the patient has incompetent facets or some other issue. For these extramedullary intradural tumors, we have to think about having some instrumentation available for those, depending on how involved the surrounding structures are. And again, typically they're benign. Myxopapillary ependymomas I put in that category. The phylum extends from the conus, but it's not really considered intramedullary. These are found more at the level of the cauda equina, and they're resected much like other extramedullary intradural tumors. Just as a quick pearl, when we're taking out these myxopapillary ependymomas, because they're attached to the phylum, which extends from the conus, when resecting it, you can first, as much as possible, try to dissect it from the cauda equina, but when it comes time to cut the phylum, you don't want to cut the phylum inferior to the tumor. The tumor can actually retract up under your duodenum and make it more difficult. So you first cut above it and then below it. And these can be cured with a resection. And now onto extradural tumors. Again, the majority of spine tumors that we see are not intramedullary or intradural extramedullary. They're these extradural tumors. And within that category, there are, of course, the primary spine tumors and metastasis. Oh, let me go this way. Among metastases, this is a list of possibilities. The list is longer, but these are the most common in descending order. And so what we see most is lung cancer, metastasizing to the spine. That may differ from nation to nation depending on how much people smoke and how much tobacco is used. But these are the most common. Even among this list, many of you may look at this list and say, you know, if I see a melanoma, I'm going to prepare for high blood loss. If I see a renal cell tumor, I'm going to prepare for high blood loss. Prostate tumors, these are osteoblastic tumors. I'm going to need a good drill. There are a lot of small surgical considerations depending on the pathology, on the histology. And so we can't approach this like we approach spondylosis or trauma. We have to understand the medical side of it, and that requires a biopsy. And we'll talk more about that. So again, among the extradural tumors are intraosseous tumors. Here, this looks like metastasis. On the T1, it's hypointense. You can see some here in the pedicle. These are images that will show you an example basically of a purely intraosseous metastatic tumor without any epidural extension. And so, you know, just purely mechanically, we may look and say, well, there's a lesion there that may be destabilizing the spine, but currently is not causing any stenosis. Now we come to the level of spondylosis. Say, here's something that may be unstable, not causing stenosis. But until we understand the pathology of the tumor, we're not going to know how to treat it surgically. Some tumors require a complete resection. Some require a complete resection for cure. Some require a complete resection or an en bloc resection without first coring it out with margins to prevent spread. These things we need to know before going in. If you go in on a sarcoma and start drilling out the pedicle, you have hurt that patient. You have hurt that. So these are things we have to consider. So even with an intraosseous tumor, purely intraosseous, not causing any obvious instability or listhesis and no stenosis, it's better to know. So what are the surgical considerations for these types of tumors? Well, are they causing a deformity? We may have to deal with that. Is there... Just wiggle the cord here. There we go. Is there retropulsion? And I use that word precisely because I'm not talking about epidural extension of the tumor. I'm talking about a pathologic fracture with some retropulsed bone. We approach retropulsion from a pathologic fracture differently than we would extraosseous extension of the tumor. So again, we have to look at the anatomic considerations. We have to consider the oncology as well, or biopsy. These are things that we may be involved in even with an intraosseous tumor, purely intraosseous tumor. More importantly, recently, this superhero, who is a neurologist, not a neurosurgeon, Dr. Patchell, he started to and continue to do a lot of work on spinal metastasis. And what he found over the years, and I would encourage you to read at least this paper from Lancet. You guys hopefully will all have these slideshows available to you, and the papers that followed. What Patchell discovered was that if there is extraosseous extension, there's epidural tumor with metastasis, then our surgical approach should change. It used to be, well, radiate it, do some chemotherapy, call us if the guy needs laminectomies. Call us if there's an acute neurologic decline. That's not the case anymore. Local control, biopsy, all these things are coming into play. So what Patchell gave us with one of the few, it's important to know this study, because it's one of the few randomized controlled trials in neurosurgery. He gave us a protocol, and everybody loves protocol. Okay, we can stop thinking, I see that, I'll do this, and everybody will be happy. It's not the case. And so I'll show you some cases after this that still follow what Patchell is telling us, but there are subtleties we need to understand. And like I say, if you approach it purely mechanically, like we do spondylosis, we're going to get it wrong in many cases. Okay, so what did Patchell say? He said for these studies, these are the inclusion criteria, these are the exclusion criteria. We found that people who were included in the study did better. And what does that mean? They didn't survive longer. There actually was some survival benefit to operating before giving radiation. Surgery with radicompression and radiation is superior to radiation alone. In fact, so much superior in allowing the patient to walk for a longer period at the end of their life of cancer, that the study was stopped. It was one of these studies where the standard deviation was so great that it was stopped. And so we have this protocol based on this study. But we see here there were exclusion criteria. So we need at least a biopsy to know what we're going to do. Because what if it's a radiosensitive tumor? It doesn't mean we don't operate on it and it just gets radiation. It means now we have to think about that. We have to think about what to do with that. And a lot of the other neurosurgical tenets that you understand start to apply. Okay, so we have these criteria. We now see tumor with epidural extension. We come to try to understand the pathology. What if we find that although we see a lot of lung cancer, this patient has specifically small cell lung cancer that's very radiosensitive? I may not need to operate at all. This patient may walk for a long period of time, not be disabled prior to death, just with radiation. And of course, we need to know the neurologic exam. So let's start with a case. I'm going to give you a case, and then on the next slide, I'm going to give you two possible MRIs, or two possible images that apply to this person, that would change our approach completely. So very simple. 60-year-old female with back pain, functionally limiting back pain. It is non-mechanical. So we say that's biological back pain. Lying down, standing up, walking, the pain is the same. It's biologic, not mechanical. No trauma, no radicular symptoms. Okay, so she tried therapy, medicines. Now it's been 3 or 4 months. The pain is worsening. She has some tenderness to palpation on her spine. Someone gets an x-ray and sees a lesion. So she goes on to further imaging. Now, what if this is the imaging? Let's forget this for a second. What if the imaging shows a purely intraosseous pathologic fracture and a metastasis? No stenosis of the canal, no real deformity, just a pathologic fracture, completely intraosseous metastasis. Well, okay, we'll look here and say, well, what do we do? First, we need a biopsy. If she doesn't have a prior history of cancer, you need a biopsy. If we find that this is a lymphoma, well, this can be radiated and treated very straightforwardly. If you find it's a multiple myeloma, again, it can be treated very straightforwardly with radiated small cell lung cancer. And then there are moderately radiosensitive tumors: prostate, breast, renal cell, Then there are the ones that are more resistant to radiation, non-small cell lung cancer, that sort of thing. So in this case, right now, based on deformity, stenosis, I'm not planning any surgery. Based on the pathology, I may or may not plan surgery, depending on if there ends up being epidural extension in the future. But if there is epidural extension, 2 months later, a little epidural extension, and she has a radiculopathy. If I know that it's lymphoma, I might call the oncologist and say, hey, let's get this radiated right away because lymphoma will melt away and the radiculopathy will get better. If I know from the biopsy that it's non-small cell lung cancer, well then we may have to follow that. That there may be things we need to do to help that person remain ambulatory. Okay, so you take the same patient and instead we have this imaging. It's intraosseous and has epidural extension. It's got spinal cord compression. All these things are being met. Do we need a biopsy? I mean, we have stenosis. We have significant stenosis, displacement of the cord. She only has back pain. There's no deformity. Do we need to do surgery? If it's lymphoma, if it's small cell lung cancer, if it's myeloma, we may not. She should get into radiation quickly. At Ohio State, where I trained, believe it or not, the radiation oncologist would come in at night and start radiating people if they had these types of lesions. Because the alternative, especially in myeloma, is a long construct and a difficult process after that. So again, biopsy. It's important to know the histology. Okay, now we have another case. We say radiosensitive tumors radiated. You saw that. If that's radiosensitive, let's just radiate it, especially if she has a few symptoms. Here's another one though. Just back pain, biologic back pain, not mechanical. She got in a little car accident, some small back pain, but it's getting worse now. It got so bad, it's rapidly progressing that she comes to the emergency room. We get a CAT scan and an MRI, and while she was in the MRI that night, this is a case we had. She goes from 5 out of 5 to 1 out of 5. She loses her legs. So what we have from the emergency room are some x-rays. We see there's something happening here. Maybe she was in a car accident. Maybe she had a burst fracture that's now unstable. There's this on the CAT scan, certainly a lot of erosion of the bone. There's deformity. And then while she's in the MRI, this is what we see. So what do we do with that? Well, am I going to get a biopsy and see if it's myeloma and call the oncologist and say, let's get her on for radiation next week? No, she just lost her legs. So a lot of the protocols that Dr. Patchell talks about in his papers are worthwhile. And he doesn't exclude the possibility of taking someone emergently with a radiosensitive tumor. You still have to be a neurosurgeon. You still have to prioritize, obviously, disability. And so in this case, we took her directly to the operating room. Right from the MRI, we take her to the operating room for decompression. And we start with the posterior decompression, do a corpectomy from behind, some screws above and below. So now we have local control. And that doesn't mean just laminectomy. You want to get around front. You do need some kind of anterior decompression as well. So if this is non-small cell lung cancer, this is the time to get that local control. We send the frozen section and say, oh, this might be lymphoma. Put our heads down and say, maybe, but we know this couldn't have been radiated. Don't think that because it's a radiosensitive tumor, we shouldn't be doing surgery. Also, don't assume that with a small surgery and a little laminectomy, then you can take them to radiation. This has to be a big surgery. This can't be a small laminectomy. The anterior column was disrupted. If you disrupt the posterior column, this patient will become more deformed. And so here now, we are putting screws in and decompressing with 2 procedures because we went anteriorly to a lymphoma, which generally you hope not to operate on. Everything improves to some extent postoperatively, and we find that actually the final report is multiple myeloma. Still a radiosensitive tumor, not one that needs surgery, according to Dr. Patchell, because it's radiosensitive, but that's only if they're not actively neurologically declining. But I will say, if it's radiosensitive to that extent, lymphoma or multiple myeloma, and they have one neurologic symptom, pain, even a little weakness, it is reasonable to try to start radiation very quickly and save that person from a large surgery. So if we see something, we think it may be myeloma, and we have time to think about it. Even in this case, we have a case like this. There's epidural extension, pathologic fracture, not too much deformity. This makes me nervous. This doesn't look great. There's a lot of stenosis of the cord, but the patient just has some back pain. And so what do we do in this case? You don't have to rush them to surgery. You can, especially if you think it may be myeloma. There is a medical workup for myeloma. You may have time for a small biopsy if needed. So there are things that we can be involved in. But in these cases, you still have time for a biopsy. Yeah, I will add, especially for myeloma, one other surgical option for pain is vertebroplasty when there is no stenosis and deformity. And I do want to mention that as one other surgical option. They, of course, look in 3 months, form some significant compression fractures. And I bring this up because in this case we did vertebroplasties, but you can see there are still pathologic fractures above. But it is recommended to do, say, only 3 vertebroplasties in a row. Beyond that, you can actually get methacrylate into the venous system and cause an embolism. And so 3 in a row, see how they do, and then if they're still having pain as she did, we added the other 2 levels, and that pain improved. And so throughout all this, like I say, the goal is not to teach you everything about spine tumors, but to tell you that when you are approaching a spine tumor, even if it's not intramedullary or intradural, if it's intraosseous, and you feel like, well, this is something that I deal with all the time with trauma and spondylosis, that's not the case. It's better to, if you have the opportunity neurologically and radiographically, if you have the opportunity to get a biopsy, then when things do go south, you know what your approach can be. Any questions? Very good, thank you.